All right. Good evening, everyone. Thanks for joining us on a chilly Thursday evening. My name's Karen Aarons. I'm one of the GPs with the Western Health GP Integration Unit, along with Joe Silver, who's in the same role, who's here with us. And we've got Yvonne from the PHN as well. And we've got a couple of wonderful geriatricians who've joined us this evening, who I'll introduce shortly, to give us a session on chronic wounds and delirium in the aged care population. I think there's enough here now, so we'll kick off. So first of all, I'd like to acknowledge Northwestern Melbourne Primary Health Network and Western Health. I'd like to acknowledge the traditional custodians of the land on which all our work takes place. And in this patch, that includes the Wurundjeri Woi-wurrung people, the Boon-wurrung people and the Wadawurrung people. And we pay our respects to elders past, present and emerging, and as well pay respects to any Aboriginal or Torres Strait Islander people in the session with us today. So just some housekeeping before we kick off. If you've been to these before, you'll know how it works, but for those new kids on the block, everyone's muted. So there's two ways to communicate with us or with the speakers or with Yvonne at the PHN. There's a Q&A box that you'll see usually down the bottom, and you can put questions in there. We will be looking at those along the way. Sometimes they'll get answered directly, and sometimes we'll hang on to them till the end of the presentation for the speaker to answer then. The session is being recorded, so questions will be asked anonymously in order to protect privacy. The other thing is try and make sure you've joined the session with the correct name in the Zoom box. And look, if you haven't managed, that helps with the CPD points. If you haven't managed to do that for some reason, you can use the chat function. Now, that chat function is really just to communicate with everyone at the PHN if you need to put your correct name in for that purpose. And that's easy to do. So let me introduce our lovely two geriatricians. So we've got Elizabeth Daperin, who's a geriatrician working at Western Health. And she's got a special interest in chronic wound management and has been working at the wound clinic since 2011 and has done significant further training in that. And after that, we'll have Dr. Ines Tucker, who's another geriatrician at Western Health for over 10 years. And she's got an interest in community geriatrics, particularly residential care and behavioural and psychological symptoms of dementia. So I'm really looking forward to these sessions because it's very relevant to general practice and the work we do. As always, we have a quick chat about health pathways. Most of you here will know about health pathways, but just in case you don't, it's provided by the PHN. It can be accessed from the PHN website. And it's a one-stop shop for clinical and referral pathways and resources at point of care. So with regards to Liz's session first in chronic wounds, jumped ahead. Backtracking. So as you can see, it's evidence-based and written by GPs who have been employed as clinical editors by the PHN. So with lots of material and how to refer and services available within. Now on to the general wound care stuff. So there is a section on the health pathways on general wound care. There's a few related pathways. I won't go into this in much detail because I know Liz will be talking to most of this, but you can see, like most of the pathways, there's an assessment page with some red flags and some factors that might affect healing there. There's some management page. There's a range of factors affecting healing there you can have a look at. And then the referrals as usual, and there's a few options there for that. And if you haven't registered already for health pathways, I encourage you to do so because it's incredibly useful from your desktop when you're sitting in front of a patient to quickly jump on and have a look at some of this stuff. So that's showing you how to register on the health pathways, on the PHN website. All right, so I'm going to stop talking now and hand over to Liz. Thank you, Liz, if you're happy to take over from here.
Hello, so I'm Elizabeth Dapper and I'm a geriatrician at Western and I love wound management. I work at the wound clinic there and we accept referrals from the western suburbs of Melbourne, and I think for the more northern suburbs, Royal Melbourne, and I think also Broadmeadows have got wound clinics. I've got a lot of slides here and there's a lot of information. So some of the information I have more down here for a resource rather than to speak through tonight, because there's sort of some lists of dressings here and there. And I think there's probably not a lot of need to talk through them all, but just have them available. Okay, so I think really what I wanted to talk about tonight was really about the principles of wound management, and because I think as a doctor that tends to be a lot of our role is to try and work out what's going on and what we can do to management. So I've always summarised sort of the principles of wound management is into assessment and management, and really as part of assessment is defining not only the etiology of the wound but what the barriers are to healing. And my feeling is if actually you can do this and identify and manage the different barriers, this is a good way of working through the most complex, the most simple of patients, and really it's quite an effective way of treating even the most complex of patients. So with wound management, the common saying is you need to consider the whole patient, not just the hole in the patient. And by doing this, you can often come to a good outcome. So for the initial part of the assessment is we like to define the etiology. So what the barriers are to healing. So in regard to barriers are to healing, what are the systemic barriers to healing? And then what are the local barriers to healing? We then like to do a reproducible wound assessment as a part of our assessment. And that way you can compare time you see the patient to the next time you see the patient to determine how things are going. And then once we've done that, we can then formulate a management plan, working out what our goals are for this particular patient, managing those systemic barriers to healing, and then also selecting an appropriate dressing to manage the local barriers to healing. So wound management, I guess there's lots of barriers to healing in patients. So arterial supply, if a patient's got poor arterial supply, their wound isn't going to heal. If someone has a spreading infection, such as cellulitis or osteomyelitis, pressure, and particularly in people with neuropathy, chronic venous disease can be a barrier to healing, lower leg edema, whether it be from lymphedema or heart failure or whatever it may be from, diabetes, malnutrition, smoking, continence and hygiene, gout, multiple medications can form a barrier to healing, vasculitis and other inflammatory conditions, skin cancers and other skin conditions. And patients can have sort of as many or as few of these, but often these, identifying these can help us work out why a wound isn't healing in this particular person. Then after we've looked at our, we've assessed and looked for our systemic barriers to healing, we then like to look at the wound bed itself. And so not only, I guess, and look for reasons in the wound bed why a particular wound isn't healing. Is a wound full of tissue? Is a wound full of non-viable tissue like slough or necrotic tissue? So a wound bed normally heals by having clean granulation tissue and then with the epithelial tissue spreading across the top. So we need to make sure that, I guess, slough and non-viable tissue is debrided. Is there localized wound bed infections or inflammation? Is that why a wound isn't healing? I guess we need to make sure there's no localized wound infection for a wound to heal. We need to make sure there's moisture balance in a wound for it to heal. So a dry wound, you can't get epithelialization across the wound bed. And in a wound that's too moist, you end up getting maceration and damage to the wound bed. So you need to make sure you have moist wound healing, but it isn't too wet to get local wound healing. And also make sure the edge of the wound is advancing. So here's just a picture with some healthy granulation tissue and the pink epithelial tissue growing over the top. But if a wound is filled with like necrotic eschar or slough, or here as well, slough or hypergranulation tissue, which is sort of red raised sort of cherries of granulation tissue, then these haven't got a healthy wound bed. So you're not going to get that wound healing. Infection and inflammation. This here down here is a picture of a Mycobacterium ulcerans infection ulcer, which is not common, but a possibility in Melbourne. And this is a picture of a wound with spreading cellulitis around and a local wound bed infection. And here's a picture of, I guess, moisture. So it's a dry wound here, and without moisture, this won't debride and we won't get healing of this wound. But on the other extreme, there's got too much moisture in this wound, and so we get the wound bed is actually enlarging because there's maceration and damage to the wound edge. So we need to make sure there's a balance of that wound moisture. And then here's a wound edge where there's, I think, some undermining here, and then sort of an inflammatory and a ischemic edge on this wound. So we need to have a healthy wound edge for healing. So I guess they're identifying what's going on in this particular patient and this particular wound. We then like to do a reproducible wound assessment. So in the clinic, we take photos of the wounds, but if that's not possible, measuring the wound, looking at the size and the depth, describing exudate, how much exudate's coming out, how much of the dressing is it dripping in front of your eyes or is it quite dry, the appearance of the wound bed, how much slough is there, how much necrotic tissue is there, suffering, looking at if there's undermining at the wound edge, and documenting this down so when you see the patient again, you can compare, have things improved or have they deteriorated. So once we've assessed our wound, we've looked at what systemic barriers there are to healing and looking at the local barriers, looking at the wound bed itself, looking at the tissue and the infection and the moisture balance and the wound edge. We've assessed our wound. It's then start to thinking about a management plan. So the first thing we do in wound management is determine what is the actual goal for this patient. And the majority of time, our goal is for healing. But occasionally we do get patients who really that's never going to be a realistic goal. And I think it's important to identify that at the start, or perhaps even once you've started treatment, whether that's actually not a possibility. And maybe our goal becomes preventing deterioration and preventing infection, or actually palliation. And so I think it's important to identify that goal, and it'll let the patient or the carer know so we know which direction we're going to. And as well as having an ultimate goal, I think it's also important to think of an intermediate goal. So is the wound really painful? Are we really just trying to make it more comfortable for the patient? Is it one of those patients who've got a wound that sops, it wets a huge amount of exudate and it's wetting their slippers, it's wetting their bed, it's causing, sogginess of the carpet under where they sit? Are we really trying to manage how much fluid's coming out? Is it smelling and they can't eat their dinner, their family are really complaining about the smell? Is that what the problem is? So working out not only what our ultimate goal is, but what our interim goal is, I think is also really important. Once we've identified what our goals are, I think it's then important to go through what our systemic barriers to healing are and see if we can do something about them. So if someone has if we think someone has poor arterial supply, investigating that with a Doppler and referral to a vascular surgeon if we think that's what the problem is. If we think someone has a spreading infection like a cellulitis or an osteomyelitis, investigate that if that's appropriate, but treating them with a course of antibiotics for that particular complication. If there's pressure involved, do they need to see a podiatrist to get offloading in their shoe? Do they need to see an occupational therapist to get pressure offloading for their wheelchair or for their air mattress or those sorts of things? For chronic venous disease, the management for some people can be getting their veins, having intervention for their veins done by a vascular surgeon. But for most of the people, it's compression therapy, whether that if that's appropriate. But looking to see, is there something I can do about that? So going through the different areas of what the barriers are to healing and ticking those off, doing what we can about them, making sure someone's diabetes is well controlled. If they need to see a dietitian, if they've got a pressure ulcer and they're malnourished because of other health conditions, getting them to see a dietitian or take supplements or increase their protein intake if possible. Smoking cessation if possible, but even reduction can be helpful. And going through their other medical factors. Do we think that actually this is a skin cancer or something like that? Do we need to take a biopsy? And often patients don't, as I said, don't often just have one of these factors. They've also often got multiple of them. And working through them all, I guess if you reduce those barriers, you're more likely to get healing for that patient. So finally, once we've identified our goals and managed our systemic barriers to healing, we then need to choose an appropriate dressing. And the dressing is really aimed at creating an optimal environment for healing. So managing those local wound bed barriers we were talking about, like the tissue quality of the wound bed, managing a local wound bed infection, managing the moisture balance and all of those things. And really getting wound bed preparation, making a wound bed ready to heal, cleaning off the necrotic tissue, cleaning off the slough, giving a nice, healthy, granulating base, allowing the epithelial tissue to grow across. So that's, I guess, the first purpose of a dressing. The second purpose of a dressing is to manage the wound symptoms and reduce comfort. So managing that odour, managing that pain and managing that exudate. And finally, it's to protect the tissue and prevent the wound enlarging and worsening. So as I said, we're selecting appropriate dressings. We're looking at the tissue of the wound bed, if there's localized wound bed infection or inflammation, looking at moisture balance or moisture imbalance, and looking at the edge of the wound. And I guess doing those things can help us choose the appropriate dressing. Unfortunately, with wound care, I guess there's other things that we often need to think about. Unfortunately, unless you're covered by DVA, the cost of dressings is actually a really important factor. Unfortunately, people have to pay for the dressings themselves, and often they have to pay for someone to perform the dressings as well, or maybe the GP clinic is paying for dressings. So really thinking of the cost and the availability of dressings is an important practical consideration. I'm thinking of the goal of care. I guess, and making sure that the product that we're choosing, I guess, matches the practicalities of the goal of care that we're trying to achieve. Thinking of the skill of the care provider. There's no point choosing a complex, difficult dressing to apply if it's, I guess, a non-skilled care provider providing the care. Thinking of the comfort of the dressing. Some dressings are more comfortable than others. Some are quite painful, and so making sure we match the dressing with the comfort for the patient. Are there symptoms to manage? So we're talking about odour and exudate. I guess the size and depth of location of wound. So one of those big sort of a large pad on a wound is going to be good on a leg, but on a small area that you want to sort of make the dressing conform to the location, then perhaps a thinner foam type dressing that you can conform to a heel or conform to a toe or can cut to size might be better. So thinking of those sort of practicalities. Patient factors, so I guess, is the patient able to take the dressing on and off themselves? And also frequency of dressing change. There's no point using, if a patient can only have a dressing done once every week, because that's the only time a carer can come, then we need a dressing that's going to last for a week. If someone wants to have a dressing changed every day, there would be no point using an extremely expensive dressing because you would be needing to change it every day. So I guess these are factors that can be helpful to think about in the back of your mind as to choosing what sort of dressing you choose. So when we think about dressings, I like to think about several things. The first is actually I start off before the dressings and think about skincare. After that, we think about primary dressing, and a primary dressing is the dressing that comes in contact with the wound. So this might be an ointment, it might be a mesh, but actually it might be an all-in-one dressing, like a foam that's impregnated with something. So a primary, some wounds just need a primary dressing, but some, if you're using a mesh or an ointment or something like that, you would then use a secondary dressing, which goes on top of the primary dressing. You need to think about how you're going to fix the dressings in place, so fixation. And then finally, you need to think about other things. Is there compression I need to use for edema or venous disease? Do I need to think about offloading for a foot wound that's pressing in someone's shoe? Do I need to think about other skin protection, for example, a skin tear on someone's arm? Do I need to think about other pressure care? So, for example, a sacral pressure wound or a something like that, maybe for somebody in bed or someone in a wheelchair. So in regard to skincare, I think there's a few, to me, practical rules we need to think about. It's important to keep a dressing dry. If a dressing gets wet, you need to change it. So patients realistically need to be able to cover the dressing with a plastic bag and keep it dry when they shower. If they can't, then unfortunately I tell them they just have to bird bath. They just have to sponge bathe until there's a time when they can. So that's the first thing. The second thing is tap water is okay to wash a wound. If a wound's been sitting there open for 3 months, 6 months, 12 months, then tap water is fine. If water's clean enough to drink, it's clean enough to wash a wound with. And so often with patients with large leg wounds, I say to them, keep the dressings dry if they're staying intact. But actually, if the nurse is coming to do your dressings, it's okay to take down your dressings, have a shower, and then the nurse can come and wash the wound in the shower. And then when the nurse comes, they can redress the wound. So it's okay to use tap water and wash a wound in a shower. Other things we think about is a cleanser for the actual skin. So you can see in this picture here, this person's got a large amount of dry skin flakes. So we'd suggest maybe using a face washer or a chuck to try and exfoliate some of that skin, because all that dead skin is going to have be a lovely place for bacteria to live in, and which can then, I guess, increase the bacterial load around the wound. So using maybe a soap-free wash and a chucks or a face washer to exfoliate all of that. Sometimes we recommend a wound soak to the actual wound bed. Ideally, they're great. They supposedly break down the biofilm on a wound, but sometimes it's not practical because things like Prontosan require a 15-minute soak of the wound. And realistically, in a clinic, that's often not possible. And even sometimes with district nursing at home, that isn't possible either. But sometimes it can be very helpful. Acetic acid I'll speak about later, but diluted acetic acid or vinegar is very helpful for Pseudomonas wound colonizations. Occasionally we use a betadine wash on a wound. We don't use it very often because betadine is actually toxic to macrophages and actually impairs healing. But for very heavily colonized wounds or for palliative wounds, we sometimes do use neat betadine on a wound. Then it's also important to think about moisturizer, and especially for skin like this. If skin is dry or it's unhealthy, then it's more likely to break down further. So we want healthy skin to try and prevent further wounds developing. And then finally, skin protection. So if a wound is very wet, maybe using a barrier cream around the outside to protect the skin from the exudate that will macerate further. You can get skin preparation sprays, which protect the surrounding skin from tapes, so to prevent tapes causing skin stripping or damage. And then skin preparation wipes are similar. You can wipe down with a little gauze wipe of skin preparation wipe to try and protect the surrounding skin from tape causing damage. So thinking about dressing mnemonic, TIME. So the first thing is tissue. As we said, our aim of wound dressing is to debride the black necrotic and yellow slough to reveal a healthy granulation tissue and then ultimately get epithelialization across the top. So I guess there are different dressings that we can use to clean a wound bed. To remove a dry eschar or slough, I guess we're going to have to add moisture to get rid of the dryness. And then there are, I guess, examples here of some dressings that we use, which would help remove something like this. To remove slough on a moist wound bed, I guess there's a list here of different things that we often use. And I guess it just depends on what's available for your patient, what's available in your clinic, cost and those sorts of things. But there are some examples here. If we're removing a dry eschar or a dry slough, then we want to use a moisture adding product. And if we're going to try and get rid of a wet product, then we want to use something that's not necessarily going to add moisture, but we're going to be able to use that's going to be able to, I guess, ultimately allow fluid absorption to try and get that moisture balance. Hypergranulation tissue, as we said before, sometimes when a wound is infected or if there's an excessive amount of moisture, rather than getting that lovely, clean, nice granulation tissue, you get granulation tissue that forms these little cherries or these little pockets, and they stand proud of the wound bed. And this is a sign of often wound infection and also excessive moisture. The problem with this is you can't get epithelialization across the top. It's not a nice, healthy granulation tissue, and so a wound like this doesn't heal. I guess there's different ways of managing this. The first is sometimes you can debride it, like manually debride it. We don't do that. You can use things like silver nitrate to try and burn it off. Managing a wound infection with antimicrobials and managing the fluid balance can sometimes help. And there's also a dressing called Mesalt, which is a hypertonic saline dressing. So it's a highly concentrated salt dressing, and I guess it prevents this hypergranulation tissue, and once that's managed, you can then manage the wound as usual. The other thing is, I think it's important, we were talking before, if someone has a black eschar or a dry eschar, we try and use a moist dressing to get rid of it. The only exception to that rule is if someone has an ischemic foot and they've got a black clap like this, either on a heel or on a toe, we actually just want to keep it dry. If there's no blood supply, keep it dry and don't debride, because the problem is if there's no blood supply and you open it up, the wound's not going to heal and you're going to end up with now an open wound rather than a nice protective black eschar on the top. So in these circumstances, we just paint with betadine to try and reduce the bacterial burden and just use a simple protective dressing. So all other necrotic eschars, all other dry slough, we would try and add moisture and try and debride. But if there's a foot that has no blood supply, that's an exception to that rule. So after we've thought about tissue, we then think about infection. So infection in a wound is the presence of proliferating microorganisms, and it causes local tissue damage, and it impairs local healing or causes a systemic response. So I guess there's this wound infection continuum, and chronic wounds are all going to be colonised. And colonisation is where you've got, they're all going to be contaminated, where you've got bacteria living on the wound bed, and chronic wounds are actually often always colonised as well. So those bacteria on the wound bed are multiplying, but they're actually not causing inflammation. They're not causing any localised tissue bed damage. After that, often most chronic wounds can sometimes have localised wound bed infections. So that the colonising bacteria, or the bacteria that are multiplying on the wound bed, are actually causing inflammation and invasion into the wound bed, and are causing damage to the wound bed and inflammation, and so impairing healing. And so a localised infection we treat with topical antimicrobials or an antimicrobial wound dressing. Sometimes those bacteria can actually spread further. They can spread further than the wound bed and cause a spreading infection. So an osteomyelitis if they spread deep, or a cellulitis if they spread. And so if there's evidence of a spreading infection, that's when you start to need systemic antibiotics. And finally, the continuum is that sometimes people can become severely septic because of a wound infection that's spread just beyond sort of the cellulitis or the osteomyelitis. But by looking at this, it suggests that actually any chronic wound that you take a swab of is going to grow bacteria, because there's always going to be the contaminating or colonising bacteria. And so a wound swab actually is not very good at discriminating if there's a wound bed infection, which is this, or a spreading infection, which is this, which is the things that we want to treat. So looking at this, I guess there's different factors where then on what I'm suggesting is actually wound bed infection is actually a clinical diagnosis rather than a lab diagnosis. And often what we see in wound bed infections, chronic wound bed infections, we either get hypergranulation we were talking about. The wound bed doesn't look healthy. It doesn't look like that nice, healthy, lovely granulation tissue. It looks either bleeding, it breaks down easily, the wound starts breaking down. We get that pocketing that we saw in that heel picture. The wound is enlarging, there's delayed wound healing, there's maybe more pain, there's maybe more exudate, there's maybe more malodor. So these are often the signs that we see with a local wound infection. And then the spreading infection is the things that we would normally look for with things like cellulitis or osteomyelitis. So investigations for wound infection, as I'm saying, wound infection to me is a clinical diagnosis. The aim of the investigations are really just to determine if there's a specific organism that we should be focusing on, looking at resistance and sensitivities of the organism, identifying complications and guiding management. So really, sometimes things like a wound swab can be helpful if we're looking to a particular antibiotic to treat an infection. Bloods can be helpful, looking at signs of systemic inflammation, and imaging can be helpful if we're looking for things like osteomyelitis. But it's not the first line for diagnosing a wound infection. So performing a wound swab, what we're saying is that actually we don't want those colonising or contaminating bacteria. What we want is the bacteria that are spreading deep in the wound bed causing problems. So actually the best way is to clean a wound bed, the best way to get a wound swab is actually clean the wound bed first. Make sure that you've got a clean wound bed, not with anything antimicrobial, but with normal saline. Get rid of the dirty dressing, sometimes even debride with a scalpel we do. And then from the cleanest area of the wound, press firmly and deeply, because what we want is those bacteria that are in the wound bed causing the inflammation at the wound bed. And that's the best way to get an idea of actually those organisms. And things to consider about when you're looking at a wound swab result. First of all, clinically, is there an infection or is this just contamination? And my suspicion is actually a large amount of the wound swabs that we get results for are actually contamination rather than, or colonisation rather than a true wound bed infection. So the second thing we think is if there is an infection, do I think it's just a localised wound bed infection? And if that's the case, I'm going to use an antimicrobial dressing. Or do I actually think there's a spreading infection and think they actually need antibiotics? And finally, if a wound swab hasn't been done, is it actually indicated? Is it going to change what I do? Or if it's not going to change what I do, I probably don't need the swab at all. About antibiotics. So localised wound bed infections we treat with antimicrobial dressings rather than antibiotics. We use antibiotics for spreading infections. Occasionally we use antibiotics when there's a localized wound bed infection that can't be managed with wound care alone. So in someone who's immunocompromised, in someone who's got a severe Pseudomonas wound infection, then maybe we might use antibiotics for a week to get things under control. But the majority of the time, localized wound bed infection in a healthy person is treated with antimicrobial dressing. We don't use antibiotics routinely for the promotion of wound healing, and really we don't use it for more than a week or two. It's really just to treat that spreading infection. And the only time we use topical antimicrobials is really for, we use topical metronidazole gel for malodor or in fungating palliative wounds, but we don't use topical antibiotics because they promote resistance. So the problem is as well is that wound infection, treating the infection alone isn't going to actually fix the problem. We need to make sure that we address the other factors that are causing this wound not to heal. Treating the infection alone won't fix that. We need to treat the systemic factors and also those other wound bed factors that we were talking about. So some examples of some antimicrobial dressings. Oh, that's fine, I'll come back to it. So then once we've thought about wound infection, the next is thinking about moisture balance. As we said before, you need a moist wound bed to promote healing, but excessive wound fluid delays healing and damages surrounding skin by maceration. So here are some examples of dressings that would donate moisture to a dry wound. And there are some examples of dressings that would absorb large amounts of fluid. So those heavy pads that wick away fluid, foams, things like Aquacel or Aquacel foam, sometimes negative pressure wound therapy, but that would be something from a wound clinic. And it's useful to know that things like Malalin and Cutulin and Combine don't actually absorb fluid or wick away a lot of fluid. So actually they end up causing a lot of maceration if a wound is wet. So we actually rarely use those sorts of dressings in wound clinic, and we use more those products like Zechivit Plus or those wound pads that have got the beads in them like a contained incontinence pads. So I guess this is just, again, for your records, we've got some examples of dressings which can be painful, and so we tend to avoid using on painful wounds, and some dressings that can be comfortable. And we've got some dressings here that help with wound odour. What I did want to talk about was often in chronic wound care, we get Pseudomonas colonisation. And I guess it's because wounds are a lovely environment, moist wounds are a lovely environment for Pseudomonas to grow. This lovely, moist, protein-rich fluid coming out of the wounds. And so a good way often to manage this is not only with an antimicrobial dressing, but actually doing a vinegar soak. So diluting just normal table vinegar, 1 to 10 with water, and soaking the wound for 10 minutes. It is surprisingly tolerated even in the most painful wounds, and it does a really good job of controlling that Pseudomonas. A long time ago, before I knew this, we would end up treating patients with a long period of time with antibiotics for Pseudomonas, and what would end up happening is the Pseudomonas would just grow back, and you'd end up developing Pseudomonas that was actually resistant to oral antibiotics, and would end up causing a disaster. And so using this keeps the Pseudomonas under control, and it often does allow wound healing and reduces the amount of time and reduces the amount of antibiotics you need to use. And often for those patients with a Pseudomonas colonised wound, there are often lots of them we don't actually ever need to use oral antibiotics for, because we can control the Pseudomonas colonisation using this alone. So some secondary dressing examples are things like those pads, things like foams, and those border dressings like Mepilex border or Aquacel foam dressing. So thinking about fixation, I think it's important to think about allergies and the skin condition of the person. There are different options. You can use tapes for some people, but we use often these non-compressive tubes. We sometimes use adhesive dressings. We try to avoid crepe dressings because they can sometimes cause a sort of a tourniquet effect, especially on ankles and legs. And I guess it's careful when we use tapes to try and avoid skin stripping. I want to talk quickly about compression. So as we said, for edema and for venous disease, we need to use compression. So that's an example there. So indications of chronic venous disease, lymphedema, leg edema, and I guess we've got different ways of doing it. In hospitals, we often use the 3 layers of tubey grip. So the bottom layer from the, there we go. So the bottom layer from the toes to the knee, the second layer from the toes to the mid shin, and the bottom layer from the toes to the lower ankle. And this provides some graduated compression. where am I? Bandaging. Some clinics and nurses might have ability to do bandaging, and sometimes the district nursing has ability to do bandaging for legs, and that's a way of providing graduated compression. There you can buy formal compression stocks from Jobst or from Sigvaris or Venasan or somewhere like that. You measure the pharmacies often can measure the patient's ankle, measure the patient's calf, and work out the size of compression stocking that someone needs to use. There are wraps like this, and then there's intermittent pneumatic compression. That's, I guess, provides compression on off the people's legs. I think it's important. TEDs are not graduated compression, and they don't have a role in healing or in management of leg edema. Pressure care, there's some examples of pressure care, and just a brief case study, thinking about everything we've talked about. So this is the case of a 72-year-old woman who came to our Western Health Chronic Wound Clinic. She came with a right leg cellulitis and this ulcer you can see here in the picture. So her other health conditions were obesity, she had unmanaged lymphedema, hypertension, arthritis, and she was a smoker. And really her wound symptoms were pain, heavy exudate, and a wound smell, heavy odour. So looking at this case, we identify why has this woman got a wound and why is it not healing? So identifying her systemic barriers to healing. She's got lower leg edema, which isn't managed. She's got a spreading infection. She's got the cellulitis. She's got poor nutrition and she's got obesity. She's a smoker, and there were patient factors affecting her wound care. She wasn't looking after her skin or her wound well. So there were also local barriers to healing. So looking at the wound bed, there's slough on the wound bed. We know that there's a systemic infection from the cellulitis, and there's also a localized wound bed infection. And then finally, there's moisture imbalance. You can see from this that she's got a large amount of exudate coming out, and she's also got a lot of maceration tissue here on the wound bed, causing it to enlarge. So looking at all of those things, we can now go through and address the different factors that are preventing her healing. So what did we do? First of all, we managed the cellulitis. We gave her 1 week of antibiotics. Second, the skin care, made sure she washed her leg well, but in particular, we had done a swab and she had grown Pseudomonas, and so we added an acetic acid wound soak for this woman to perform daily. We used a dressing. We used an antimicrobial primary dressing because of the localized wound bed infection. And I think for her, we used Sorbact because it was cheap and large and you could put it on. And then we used a highly absorbent pad. Oh, so there we go, Inodine. We used Inodine and Zetuvit Plus, a highly absorbent pad that could easily be changed every day. To manage the lymphedema, we added compression. We added 3 layers of tuber grip initially, and then ordered her a formal compression stocking. We referred her to Bolton Clark for wound care because she wasn't able to reach and do her wound care properly. We gave her that, and we organised that for her to be able to manage the wound. We gave her some medication. We reviewed her medication. We gave her some analgesic advice because she had a large amount of pain initially. We gave her some dietary advice, and we gave her smoking cessation advice. So we went through the list and made sure we addressed all the factors that we could have identified that were affecting her healing. And actually the outcome was that she ended up having wound healing once we addressed all those factors. And then once we had addressed healing, we needed to address ongoing management to prevent her developing further wounds. So skincare advice, making sure she knew, clean her legs, moisturise your legs, make sure your skin quality in your legs is optimised to reduce wound recurrence. Making sure she had long-term compression for prevention, so make sure her leg edema was managed. Ongoing smoking advice and ongoing nutrition advice to try and reduce her chances of wounds coming. But I think this is a simple example of making sure that if you identify the factors addressing healing, that you can end up getting healing for these sorts of people. I've got some resources here for wound management, and that's my presentation.
Wonderful. Thanks, Elizabeth.
A lot of information.
Ben, as Elizabeth said at the beginning, if you missed that the resources and the slides will all be available and sent out to you within the week. So don't worry if you didn't get all of that. There's a few chats in the Q&A just with regards to great presentation. I think it must have been very comprehensive because there's not any questions, and you've run beautifully to time. If anyone's got any questions, please feel free to pop them in the Q&A now. And Joe's got a question, and so do I, Joe. I thought of one as well. So you can go first, though.
Sorry, as a panelist, you can't ask questions. Do you know that? So there you go. Anyway, my question is, Liz, often when you go into the nursing homes, you see the residents, you know, who've got wounds and they're being given, you know, all the Tetra Paks of the various nutrients and supplements and things. What do you think of the benefit of those if they're having, I mean, you know, you'd like to think they're having a reasonable diet. That's sort of another comment about aged care, but I guess, you know,
so nutrition,
are there any benefit?
But actually it's kind of funny. So first, for pressure injuries, there is evidence that if someone has adequate protein intake, that those arginine containing supplements do help healing for pressure injuries. So there is some evidence. Someone, I think at the Austin, did randomized control study for that. But actually, the funny thing is, when I started working at Western, we actually had a dietitian in with the clinic, and she actually just increased patients' protein within their regular diet. She never recommended supplements because she felt that patients don't really use it, and she felt they were quite expensive. So she would just optimize protein. So she'd suggest to patients, you know, make sure if you're having milk, add some milk powder extra to the milk, add cream to your mashed potato, and do all of those things that to try and optimize protein. So I think it's important that someone has high protein, but I don't think it necessarily has to be done with supplements. Yeah.
Okay. We're right on time now, so I might, actually, we've just had one question pop in. Oh, there's a couple. Okay. Late entries. I think we'll be okay, though. So question number one, how can you tell if there's blood flow or not? So I'm guessing that's with regard to the necrotic foot. Mm-hmm.
I think I start simple with pulses and just looking at the toes. And sometimes toes feel cold, sometimes toes feel, they look cold and blue, there's not a lot of capillary return, there's not a lot of pulses. So it's a good indication. We're lucky in the clinic. We can do ABIs, and so we do ABIs, and we've also got access to a handheld Doppler, which we don't. Sometimes you just need to do get a formal arterial Doppler if that's possible. But I often start just simple with pulses and with toes, looking at the capillary return, how cold they are, the colour of the toes. If the foot looks ischemic, but often you might have to actually get a formal arterial Doppler.
Okay, thanks, Elizabeth. Another thank you for the presentation. With the acetic acid soak, are we trying to diligently remove all of the acetic acid post-soak with normal saline is the question?
We do try and remove it, but just sort of a brief rinse is actually fine. So what we do is we get a packet of those gauze, put the acetic acid on that, with the diluted acetic acid on that, put that on the wound. So we're actually, rather than pouring the acetic acid directly on the wound, we're putting the soaked gauze on the wound, remove that, and then just rinse it off, and that's fine. So we don't diligently then scrub it off. We don't use stacks of fluid to scrub it off, just often just removing the dirty gauze off and maybe briefly wiping it down with either some water or saline is fine.
Perfect. This one is ambulant compressions often recommended for, however, the ambulant part is lacking in the nursing home. Yeah. I'm not sure exactly what the question is, but do you want to address that, please?
Often, it's not just in a nursing home, they're right, because to get venous return, ideally you want to get a calf pump. So number one, the one thing is you want to make sure that sometimes people have some period of supine time in bed. And there's actually a surprising large number of people who actually sleep in a chair. They sleep with their leg dependent, and that causes big problems because it's really hard to get edema managed. But the other problem is you need calf pump to also help with the venous return. And there are some patients who, for whatever reason, whether it be because they don't walk or because they've got a fixated ankle, they don't get that calf pump. And for those patients, compression is still really helpful. So even if you don't have that calf pump, or even if someone has dependent leg edema, the compression can also often adequately manage the edema on its own. Sometimes it doesn't. But I guess those patients, we still do want to use compression, if that answers the question.
I think it addresses it really well. Thanks. Okay. All right. Thank you. Put your virtual hands together for Elizabeth, and we will move on. Thanks very much, Elizabeth. So next we've got Dr. Ines Tucker talking about delirium. I'm just going to show you the health pathways relevant to that. So again, I won't go into detail because that's what Ines will be doing, but you can see that there is a delirium pathway in health pathways and a few other related pathways there. And it's set out as usual with assessment and a few things to look for, risk factors, and then management. And just a practice point there. And again, just the referrals and some resources. And just in case you've forgotten from earlier, that's how you register. Sorry, I lost that slide very quickly. All right. So, Ines, I'm ready to hand over to you. So again, thank you very much. And the same as earlier, please put any of your questions. Remember to put them in the Q&A and not the chat. And we'll save them up for the end probably. Thanks, Ines.
Thank you, Karen, for the opportunity to talk. My name is Ines Tucker. I'm also a geriatrician at Western Health with Liz. And so it's hard following Liz. It's a very comprehensive talk, and I feel delirium is such a huge topic. But what I'm going to try to do is really go over an approach to delirium and have a few case studies at the end with some sort of more challenging situations, particularly around terminal delirium, which I don't think is generally covered particularly well, and is an area that we, I guess, often find tricky to it's easy to diagnose in retrospect and sometimes tricky to identify at the time that that's the approach that's needed, I suppose. So I will, okay. So we'll start with the definition of delirium is it's a severe neuropsychiatric syndrome characterized by acute onset of deficits in attention and other aspects of cognition. I think one of the real challenges with delirium is that although it's obviously been around forever, it was described thousands of years ago, getting an actual definition that is used across research and to know what we're talking about is difficult. And there's actually a lot of different terminology that's used that may apply to specific situations like encephalopathy, heard of acute brain syndromes and other descriptions. And patients may present with, just might be confused with no other information or just have behaviours, which is what we're often referred in geriatric medicine. I guess the other thing to say about that is it says in that definition that it's severe, but I think it actually ranges between mild to severe, and really we notice the ones that are severe, but we do actually know that there's probably about half of people with delirium in a hospital are not actually identified. So that's one of the challenges. How can we improve our recognition of delirium so that we can actually manage delirium better? So I guess the gold standard definition is from the DSM-5 and includes a acute onset, disturbance in attention, cognition, noted to be fluctuating throughout the day and not better accounted for another neurocognitive disorder. And that's often actually quite a challenge because delirium happens in, or people are at higher risk if they have already got other neurological and cognitive disorders. So as I said, there's no agreed definition a lot of the time, and even across the published literature, really until the last couple of decades, there hasn't been sort of agreement on terminology. One of the other issues is it's actually difficult to, there's different ways of describing it. Does it include subcortical and cortical involvement, and there's a lot of other like etiologies as well. So that is not described very well, and there's a lot of unknowns, but it seems to be that there are multiple pathways involved, whether that's sort of anticholinergics, neurotransmitters, inflammation, and many others as well. So how might delirium present? Well, most of us have heard of hyperactive, hypoactive, and often mixed versions of the two. So often the easy ones to recognise are the hyperactive, being new and unusual behaviours, agitation, aggression, often what captures the carer's concern. But also, we know that there are many people that are hypoactive, that might be more withdrawn, quiet, or have poor appetite. There are lots of symptoms, so there can, I've written a list there, but there's lots and lots of different behavioural changes, whether that's anxiety, irritability, hypersensitivity, psychomotor agitation, delusions, hallucinations, and physical and verbal aggression. And then there's a whole lot of other behaviours that go, or changes, sorry, that go with that, including sleep disturbance, poor oral intake, emotional ability, changes in communication, and people may become resistive to care or even decline their medications. So when we're thinking about delirium, there's predisposing factors in the person and precipitating factors. And I guess the ones that have the most evidence around them are previous cognitive impairment or underlying neurological disorders and frailty. But, frailty is a very general term. There's a lot of, many of the patients we see have multiple medical issues, and all of those contribute to their general vulnerability. But there's also the concept of the vulnerable brain. So older people with cognitive impairment have less cognitive reserve, and so have an increased, or I guess make it a more severe delirium, or a delirium with what would be relatively minor medical problems in younger people, like a urine infection or constipation. But in terms of the precipitating factors, they're wide and varied, and there's often multiple factors. So the approach is always to cast a wide net and try to make sure that we don't miss any easily treatable factors, particularly, and especially the ones that are common. So I've got a list of common precipitants. There's a lot of them. We always look at medications. Polypharmacy is often part of the picture, and older people, particularly those in residential care, where I've spent a lot of my practice, are often on multiple medications that put them at risk. We've got dehydration, malnutrition, and then other there's states related to underlying medical conditions like hypoxia, hypocapnia, hypoglycemia. There's a whole lot of common conditions like pain, constipation, urinary retention that are also that we see very frequently in residential care. And substance withdrawal is something to always be on the lookout for, because that's easily missed, alcohol and benzodiazepines in particular. We know people who are in that perioperative period are at really high risk as well and have higher rates of delirium. There's also a contribution from environmental factors, such as change in routine and unfamiliar environment. So to try to identify delirium better, we do have a number of screening tools, which are mostly, I think, validated in a hospital setting. And the main issue with the tools that we have is that they actually require the person doing the screening to know what the person is like over a period of time, often with the fluctuating course aspect. So this one's the CAM. It's quite relatively sensitive and specific. Actually, we don't use this one in our hospital, but and we use the 4AT, which I'll talk about, but the factors that are required are both acute onset and fluctuating course and inattention. So they must be present, and then plus disorganized thinking or altered level of consciousness. And I think the one that's, staff, the nurses who usually do these screening tools struggle with is the fluctuating course, because they're seeing the person perhaps not over a long period of time. Then we have the 4AT, which is very commonly used, and this one's actually used in our hospital, supposed to be done every shift by nurses. And this one looks at alertness, orientation, attention, and fluctuation, and then comes up with a score for how likely delirium is in that patient. So a lot of the time, when we've identified delirium, so I guess the first step is to think of delirium in the patient, and then the next step is to actually take a history and examine the patient. Try and identify any reversible medical conditions like infections, urine retention, pain, and then do some basic workup to identify any reversible, particularly easily treatable factors that may be contributing. So I'll just put a few sort of basic things that we would do there normally in hospital. Consider a chest X-ray. You wouldn't necessarily have to do that for everyone. You could clinically examine that. But I guess the things that we often ask for are an abdominal X-ray to look for constipation, because even though that, and particularly in people who have already got cognitive impairment or dementia, that is often an easily treatable and it can be missed. And we know that often people have quite a bit of fecal loading despite having their bowels open regularly. Always consider whether a CT brain would be helpful to rule out a stroke or a subacute stroke. We do find quite a few of those. And I guess in difficult diagnostic cases, we're not really sure what's going on. We might consider some of these other higher level investigations like MRI, lumbar puncture, or an EEG if we're considering seizures as a possibility. But I have to say that those are probably done very rarely, particularly the LP, with maybe an EEG that quite, would be done in a very few situations. And sometimes we don't ever find an obvious precipitant. So that's another thing to keep in mind as well. So often delirium is multifactorial. So apart from looking for infections, it's always worth doing a pain assessment, paying attention to constipation, looking at sleep disturbance. I think that often is a forgotten factor or easy to miss. Make sure that we don't miss urinary retention, and look at nutrition and hydration as well. Always review medications and consider drug withdrawal. And the other thing is to think about whether there are other possible diagnoses. So like sometimes a psychiatric condition might present with hallucinations or delusions in someone without cognitive issues, and that could actually be the explanation. And the other issue that we often see is someone who's already got a diagnosis of dementia or suspected dementia that has a change in their symptoms. Is that a delirium, or is that part of their dementia? And my approach is always to look for assume it's delirium until you've proven otherwise, exclude all the reversible conditions, address and look at medications particularly before putting that change in behaviour down to progression of the dementia. But that is a possibility as well. So the principles of management are really to look for and treat underlying conditions, ensure that there's good supportive nursing care, particularly addressing things like hydration, nutrition, pressure care, pain, bowels, so all the basics, and then look at non-pharmacological strategies. And then there are some indications where pharmacotherapy can be helpful, but it is usually the last line, and only in situations where we try to avoid it, and only use in situations where the patient is, at risk to self or others, or maybe having significant distress and agitation that can't be de-escalated with other strategies. So a lot of what I find is challenging is communication, and that can be due to patient factors as well, like visual and hearing impairment, cognitive impairment, and certainly out in the West we have many people from non-English speaking background, and that makes it, and they speak different languages to their carers, which makes it very challenging. And then looking at whether, particularly in hospital, family members and familiar items, reassurance, make sure they have this, a low stimulus environment, and trying to maintain normal routines. Pharmacological management is probably where we get the most request for advice, and I guess the thing to be aware of is that although we do use these medications, there's really not great evidence for using any of them, and I guess even sort of compared head to head, there's not a lot of necessarily an advantage of one over the other, but these are the medications that we actually have in our delirium guidelines in Western Health, and we do use haloperidol, which can be given orally as first line, but there's also the option of the risperidone and olanzapine, and in patients with Parkinsonism we would avoid all of those and use a small dose of quetiapine. There is the option of benzodiazepines, but we often don't use those first line unless, in terms of drug withdrawal, they're obviously first line there, because benzodiazepines themselves can potentially cause delirium, confusion also. In the hospital, we definitely try to avoid physical restraints. We don't tend to find this out in the community, which is good. But there's obviously no evidence that that's a benefit. So in terms of prognosis, unfortunately the news is not good. For many people, their delirium does resolve or improve over a short period of time, but for many people, that is not the case. And I guess, you know, when I was training many years ago, we were told classically that delirium improved and was a reversible condition, but I really don't think that that is true. We see quite a significant portion of patients who their delirium might improve somewhat, but you know, down the track they do not regain the same function and cognitively as they had before, and are at higher risk of like not being able to live independently, moving into residential care, and also if they didn't have a diagnosis of dementia before, then that increases the risk of dementia being diagnosed down the track. Because often what we observe is that the delirium doesn't improve over a period of sort of 6 to 12 months, and then that's their new baseline, and so they have actually declined and will most likely continue to decline after that. So I think the highest risk is being in intensive care. So if you're sick enough to be there, that's got the highest risk of delirium and the worst outcomes. But certainly it's very common. So in hospital, we know there's at least around 25% of people have delirium, and there's probably more that are not really identified. It's probably an underestimate. Yeah, we've already talked about those points. So I had a couple of cases just to, I guess, illustrate some of the things that we've talked about. So in this situation, we've got an 82-year-old with known Alzheimer's dementia, living at home with carer and daughter, and receiving some support through a home care package. The daughter has noticed slow decline in cognition and function over time. Usually she's a bit forgetful and can't sequence tasks, but has had 3 days of increased agitation, physical aggression, and become very paranoid, believing her daughter is trying to poison her and steal her money, and hence won't take any medications. She's not noted any difficulties eating and drinking, denies pain, but has noted new fecal incontinence and denies any history of falls. So she's not on a lot of medications, although she's got some risperidone already and is on an antidepressant. There's nothing much found on her examination. The vital signs are normal, and she does have some cogwheeling noted in her upper limbs, and otherwise the examination is basically normal. She's noted to have some leukocytes on a urine dipstick and some nitrites. So I guess in this situation, what's going on, it sounds like because it's an acute change over a 3-day period, that a delirium is the most likely cause, but so we need to do further assessment. There's a lot of treatable factors identified, possible. She's got new fecal incontinence, so that could well be constipation with overflow. Sorry. There's possibility of a urinary tract infection. She's been declining medications, and she's already on some psychoactive medications. So in this situation, we'd be wanting to treat the constipation with urine infection and ensure that she's eating and drinking well. We might also think about whether the risperidone is the right medication for her, given that she does have some extrapyramidal signs on examination that could be related to the medication. So the other thing is pain assessment is really important. And I often look at sleep because I think that's often quite disturbed and does contribute to ongoing confusion. So trying to identify if that is an issue and how to improve sleep. Like, is it due to pain or I guess need for toileting and or something else. And then make sure we've excluded all these other common causes like polypharmacy, renal retention, drug withdrawal. And then I guess one of the things with non-pharmacological strategies is we do try and get people we know they're best managed in their usual environment with their normal routine. And certainly delirium coming into, if someone's admitted to hospital, the hospital is not a great environment, but it completely, we know changing environments is worse for people in the setting of delirium and can actually be a cause of delirium with, different routines, different people. So if we can, we try to support people in their homes with their carers to give them the best chance of recovery. So in this situation, he's already taking some risperidone as on background. Although I've already alluded, given if we're worried about Parkinsonism, we would probably try to avoid risperidone and haloperidol. But the general options for the patient in this situation would be to avoid the medication, but if they're at risk to self or others, they're very, very distressed. And sometimes this sleep is also a big problem for carers trying to manage people with delirium or indeed PTSD who might consider a small dose of an antipsychotic. And with this, and I think some education for the carers as well around what to expect that we might need, we hope that it will improve, but there is a possibility this is the new baseline state that may need some ongoing treatment down the track. So my second case is really just to introduce the idea of terminal delirium. And so in this situation, we've got an 85-year-old man presenting with a fractured hip. Prior to the admission, he was managing at home with some mild cognitive symptoms, no cognitive diagnosis, and some community supports. He has some treatable factors, including pain and constipation, that have been addressed, but he's got ongoing fluctuation of his cognition and alertness, not eating and drinking very much, and doesn't recognise his family anymore. He's very confused and combative at times, but much of the time is sedated. And as the days drag on, he's not really getting any better. He's not mobilising or participating in treatment. And so our definition, we start thinking, well, if we've addressed everything that can be addressed, so he should have a full assessment for delirium and identify any causes or treatable causes. But if we get to the point where things are not improving and it's been an extended period of time and someone meets these criteria, which includes being physically wasted, profoundly weak, bedbound, drowsy for much of the day, limited attention span, unable to take tablets orally, and is taking little or no fluid, then we need to think about whether this is actually terminal delirium. And I think it's really hard because I think this case actually sort of demonstrates that this guy was actually pretty good beforehand, and we'd be really quite reluctant, I think, normally to diagnose a terminal delirium in this situation without giving him an extended time to try and improve. But often, if people have had a very severe delirium, and I guess maybe in a case, it didn't come across that way, but you have people who are, very, very agitated at times or very sedated, and just nothing that you do improves things for them. It can be very, very difficult to make a decision around whether this is actually transitioning to end of life. But we do see a lot of people in hospital who probably are not as, I guess, may have had an illness that, like an infection, particularly with COVID. We saw many people like this who just did not pick up, but they recover from their initial insult, but they don't, I guess, ever really pick up to the point where they are eating and drinking enough to, I guess, to maintain themselves. And so, several weeks down the track, they're still not picking up. And then that's when we might be starting to think, well, is this, a part of the terminal delirium, even though it's not presenting with the agitation or those sort of hyperactive features, it's more of a hypoactive features. So, so that's probably all I had to say. I don't know how we're doing for time. Yeah, and so obviously terminal delirium would be managed as we manage any end of life care, but in particular, so with injectable medications if required, and we use midazolam, and in some cases I've had some people with very dreadful symptoms in terminal delirium that have needed quite large amounts of midazolam, but we can also use some other agents such as haloperidol, clonazepam. And if you're really struggling, because some of them are very difficult, then palliative care involvement is useful to consider, something like levomethazine. So thank you for listening. And are there any questions?
Thanks, Ines. That was terrific. If you'd like to put your questions in the Q&A, Ines, while they're doing that, I think you might have another 1 or 2 slides with a QR code.
Oh,
Yvonne is telling me, but no, that's okay. It doesn't matter.
I'm sorry.
That's fine. No, all good. No,
all
good, all good.
Old version.
No, all good. That's fine. We can address that a different way.
Karen,
So,
I'm happy to share the slide.
Yeah, that'd be great. Thanks, Yvonne. So if you'd like to stop sharing, Ines, that would be great.
Oh, yeah. Sure.
And so lots of thank yous in the Q&As and good sessions, but again, a very comprehensive session. So, well, while we're waiting for that, I'll give you a few bits and pieces. So just a reminder, I think Yvonne's captured pretty much everybody's name for CPDs, but if you were someone who didn't have a full name in your Zoom label, then please jump into the chat and send your full name to Yvonne. That would be great. Otherwise, you might miss out. Thank you, Yvonne. There's a QR for evaluation, and there'll also be a link to that in the chat shortly. You can expect to get an email in about a week, which will have the PowerPoint slides and a link to the recording. And it usually takes about a month for CPD points to hit the deck on the RAC GP page. Now I can see Joe's got another question. Excellent.
Sorry, always burning questions. Inez, can you just comment on the PBS and medication use? Because I think it's something that makes life tricky for some of the GPs.
Yeah, look, I
Sorry.
think
The
it's
grown
really,
question.
yeah, it's really challenging. And I think that's why the medication is the area that I guess people feel least comfortable with. The PBS doesn't really support any of the antipsychotics for delirium, I don't think. And for BPSD, risperidone is actually the only one that is listed for that indication. And so pretty much, and that's the other thing to remember, that most of the delirium medications that we use in hospital, I think, there's not great evidence, and that's probably why they're not kind of listed on the PBS as well. So they're usually off-label, and so there is a cost. And certainly when we're looking at using things like quetiapine, if you're not able to say that someone has a psychiatric illness, then such as schizophrenia, then you're really not able to meet those PBS criteria, which is really unfortunate. I think makes it hard for people to access appropriate care in some cases.
And I think then there's all those other forms that you have to fill in when you're prescribing, which are probably trickier than this discussion with relatives about costs of medications.
Yep. And certainly, like, we're seeing much more in residential care that all of these medications, no matter what the indication or the diagnosis, are being called chemical restraints, and and antidepressants and everything else. So if there's not any sort of psychoactive medication, I was actually at a residential care facility recently where a nurse barged in on the assessment and insisted the relatives sign a form saying the antidepressant was a chemical restraint, even though I was happy to give a diagnosis at the time. So it's very, I think some of the language is a bit challenging in that environment as well, and the understanding of the care staff of the intricacies is not is quite variable.
Yeah, I think it's tricky, and I don't think the documentation from the department helps to make anybody feel safe about it.
No, and I guess I try to be very clear with how I document why we're using, why are we using medications and what the diagnosis, what particularly around BPSD or behavioural psychological symptoms of dementia, so that it's clear, at least to clinical people, why we're using it. But that doesn't seem to be actually that relevant to the government sort of mandated documentation. So and I kind of shouldn't get started on that, but I kind of don't agree with calling them chemical restraints in situations where there's a clear clinical need and that's justifiable. But that's another issue.
Thanks.
Thanks, Jo. All right. Well, if there are no other questions, there is just one comment, Ines, and I'm sure this is directed at Elizabeth as well, just in the Q&A, just reaching out to say how incredibly challenging the past few years must have been in the geriatrics world, and there's an appreciation there for caring for older ones throughout that time. So that was just a nice appreciation for all the hard work you guys will have faced, particularly in these last few years. I think it's, sorry, Ines.
I was just going to say, I think everyone trying to provide care in clinical environments has been through a tough few years, and I know that GPs in particular have had to step up and really manage without a lot of extra support, which sort of vanished during this COVID. So thank you to everyone.
Terrific. All right, so we'll just say a final thank you to both you and Ness and Elizabeth. They were both fantastic sessions. I'm sure everybody's, you can always tell when there've been good sessions when the number of people attending is the same at the end, at the very end, as there was at the very beginning, and there is the same number. So I reckon that's a pretty good indication, guys, that they've been awesome presentations. Thank you once again. And I'll say goodnight to everyone and bid you adieu. Thanks.
Thank you.